All right, this is our last lecture in this series, and we're going to start on chapter 64 on the ears. This is Chance. He's going to help me lecture. Okay, stop. Stop. Okay, so again, similar to eyes, there's not a whole lot going on here. The biggest thing really with ear disorders is that you might have patients who are hard of hearing. And that really kind of is the biggest thing you're going to need to know about ear stuff. And again, being hard of hearing is typically associated with age. As people age, they tend to lose their hearing if they're going to lose their hearing. There can be some other, it can have genetic component. It can be born without hearing. It can be as the baby develops in utero, they can have some problems with auditory development and be born deaf. There is quite a huge community of deaf people and sign language and people that are sign language interpreters, and they do deaf sign language to communicate to deaf people in a variety of conferences and organizations and stuff. So if you have the ability to speak in sign language, that is a very useful skill to have. If you don't, other things like using communication boards, and again with deaf people, or people that are hard of hearing, you don't want to shout at them, because when you start shouting, the pitch of your voice goes up and it's harder to hear. Higher pitched voices are harder to hear than lower pitched voices. So instead of speaking, like shouting at them, you just talk slowly and distinctly so they can hear every word, rather than talking really high and loud at them. Like, that's just annoying. So the problem with hearing loss is that sometimes it can be a little bit difficult in relationships, and you'll see this happening a lot in couples who have been married for a long time. They've been able to communicate, especially like when the kids are younger and little. You can whisper or just say little things to your spouse and they can pick up on it. But as you age, and that becomes less and less, and one partner in the relationship now can't hear as well, so they're turning the TV up, which is annoying to the person who isn't hard of hearing. Then they might have to go into another room, or they get irritated that it's up so loud, or they are asked to repeat themselves a lot, and that irritates people that are around them. They're constantly saying, what, huh, what? And then the regular hearing person starts getting irritated. So sometimes progressive hearing loss can be challenging for relationships. So as soon as somebody starts identifying that they have a hearing loss, and typically people who start developing a hearing loss, they don't like to readily admit that, or they don't notice it, because you don't notice that you're losing your hearing as much as other people around you start noticing that you're losing your hearing. So sometimes it takes a while before they will actually go get that checked out. And it's not hard. There's audiologists everywhere that put in hearing aids. The hearing aids now are excellent. You will notice that when people lose their hearing or start becoming hard of hearing, and then they have the hearing aids in, the hearing aids act as microphones. So in the human ear, you can hear somebody talking close by, and you can't hear somebody talking further away. Well, people that wear hearing aids, it's like having little microphones in their ears, so they can hear things really far away, which becomes problematic when they're in a crowd. So people that use hearing aids and hearing devices, large crowds and lots of people talking is actually very irritating to them, because everything sounds like the same volume, and it's very hard for them to start honing in on just one person when there's a loud crowd and lots of talking. The other thing with hearing is there are certain decibels. Something less than 50 decibels is not going to cause hearing loss. When you start getting up into the higher decibels, 50, 60, 70, 80, 100 decibels, that's really, really loud. And people that are exposed to chronically loud noises like that will will complain of hearing loss later in life. So this is why teenagers who bang music constantly, and their mothers keep saying, turn that down, it's going to cause hearing loss. It really does cause hearing loss. If you have high levels of decibels in your ears constantly, it will cause damage in the ears. So that's another reason in healthcare that you need to teach your patients to protect their ears when they're around excessively loud things. We also see this a lot in military people when they're around loud banging and explosions constantly. The decibels from that can cause hearing loss. People that do a lot of shooting or guns, like police officers, anything like that. If you see people that go to shooting ranges, that's why they have to wear the ear protectors, so that they don't have permanent hearing loss. So the decibels, the level of sound, and the exposure to sound over time are contributing factors to hearing loss. Another thing that is pretty common with hearing loss is this thing called otosclerosis, and you'll see it in your glossary right there. Otosclerosis, in combination with the three bones in the ear, and you should be familiar with this from anatomy, the malleus, the incus, and the stapes. Those are the three bones, and there's a picture of it on the bottom of page 1881, figure 64-1. You can see in there the malleus, the incus, and the stapes. And you see all around there that the bone that's all around the stapes there, what happens in otosclerosis is that bone kind of becomes spongy, and the malleus, the incus, and the stapes are the three bones that when the vibration of sounds come in, they sort of just kind of knock on each other, and the stapes then goes and hits that bone and makes the sound in that bone, and then the brain can interpret those sounds so you can make sense of language. Well, if that bone is not hard, if it becomes spongy, it absorbs those sound waves, and then the person starts having hearing loss. So that osteosclerosis is, otosclerosis is another cause of hearing loss. The good news is there's treatment for it. They can do a surgical procedure where they go in and actually put in a prosthetic stapes, so that it acts just like the stapes, just with the little prosthesis. And I think your book, I'll find it. I think your book has a picture of what this looks like. I'll find it in here. I'm sure, because it's pretty common to have that, and it's a pretty common, it's over on page 1896. There's a whole section on otosclerosis, and it will, it kind of shows you how they do that surgical procedure and repair that. Other things, there's a lot of medications that are on the market that cause ototoxicity, meaning it will cause hearing loss. Aspirin can do it, so people that are on high doses of long-term aspirin can develop some hearing loss. They can develop ringing in the ears. There are certain narcotics, like some of you might have heard of Rush Limbaugh. He's a famous radio talk show guy. I can't remember what the problem was, but I think that he got addicted to narcotics. It was one of the narcotics he was taking for pain, because he had something, blew out his knee or something. Then he was on these pain medications, and he had kind of abused them, gotten addicted to them. Well, the problem was it had then led to hearing loss, because the medication that he was on was ototoxic, and so then it started creating nerve damage, and then he couldn't hear. Well, the problem is he's a radio talk show host. He has to be able to hear the callers that are calling in. So he ended up, because even though he was able to get off the medication, it was irreversible at that point, so then he had to have a cochlear implant. So another reason, like these patients who have developed ototoxicities from often from drugs, even good drugs are like aspirin can be ototoxic, then the damage can be irreversible, and they can put in a cochlear implant. They're also doing a lot of work with cochlear implants with children now who are born deaf, and they're having some success with that. And you can see here this little thing that looks like a snail. I'm back over on page 1881 now. It looks like a snail, where the cochlear duct, the fluid that goes through the cochlea, and it comes up through the labyrinth structures. That whole structure, it's important for sound, and it's also important for balance. And I'm sure you guys went over this in anatomy and physiology, but just as a reminder, see this little structure right here? It kind of looks like a snail. Well, see how these three little canals, they're filled with fluid, and they're in like all three angles, so that's they help maintain your balance. There's little hairs in there, and it maintains your balance like this. So you can tell, like if you're tipping forward or sideways, those hairs that are in there will move with that fluid that's in there, and it registers with your brain. That's how you can determine your space in the world, and if you're upside down or right side up. So sometimes there are certain conditions, like Meniere's disease, and we'll talk about that later, or when people have ear problems, that they will also develop vertigo, meaning they feel like they're spinning all the time, or they can develop nausea, because people that have that spinning sensations a lot of times get nauseated, like when you're at the carnival and you're like in one of those spinny things and you get off and go, oh, I don't feel good. That's why, is because the fluid that's in those canals and because of centrifugal force gets shoved up on the sides, or it takes them a while to readjust, and that's why, is because of the fluid that is in that canals in the cochlea of the ear. So back to my hearing loss example, is sometimes they can implant a device right in the cochlea, which stimulates the auditory nerves, and that's having some success with people who are deaf and hard of hearing. Okay. So the other thing that is not in your glossary, which I think is important to know when we're talking about the ears, is a word called cerumen. Cerumen is the medical word for wax in the ears. Very, very common to get wax buildup in the ears. So when you are looking in somebody's ear, and you should know how to do this as a nurse. You should know how to look into somebody's ear, and it shows you how to do that on page 64 to page 1882. It's a little outside the scope of just a regular BSN nurse, but once you become a nurse practitioner, a clinical nurse specialist, a DNP, you're going to need to know how to look into somebody's ear and figure out, do they have otitis media, do they have cerumen buildup. So if you get a chance, kind of start playing around with an otoscope and look inside somebody's ear. If you see the little waxy, it's like a brown waxy stuff, that's cerumen. Sometimes if the whole thing is plugged up with that can also impair hearing, because the wax just builds up in that canal. The easiest and safest way to get it out is to make up a little concoction of hydrogen peroxide and water, warm water, because colder water can make somebody nauseated and dizzy. So just some warm water with hydrogen peroxide, and then you just slowly infuse it into the ear and let it sort of agitate that wax, melt the wax a little bit, and then you have the patient dip their ear down. There is a device, the end of it looks like this, and there's a long thing on it. You can go in and scrape it out. You do have to be a little bit careful, because you don't want to puncture that eardrum, the tympanic membrane that is at the end of the ear canal. But wax buildup is super common, so if somebody's starting to complain of hearing loss, check in their ears, make sure that they don't just have wax buildup in there first. Okay, so you know how when I was telling you about in the eye test, we were talking about the Snellen chart is sort of like your basic standard test for determining vision. In the world of hearing, that's the Weber's test. There's a couple different kinds, because there's a couple different kinds of hearing. There's conduction hearing that goes through the bone, and there's sound wave that goes through the air. But the Weber's test is pretty much the standard of, yeah, here it is. It's over on page 1885 in your book. And that's really the standard hearing test. And you just take a tuning fork, like if this is your tuning fork. I should have brought one. I've got one around here somewhere. You take a tuning fork, you hit it like this, and you have to hold this part so these vibrate. See the top of that, looks like that. Those will start vibrating a little bit, and you'll be able to hear that vibration. You can hear it. So you whack like this, and you don't touch these. You touch down here, and then you put it on the top of somebody's head, because that should conduct, and then you can put it behind their ear. And there's two different things that you're testing for is conductive hearing loss, and that would be like somebody who has that otosclerosis, like that spongy bone that I was telling you about. That's not going to conduct as well because it's not as hard. It's spongy, so it's going to absorb some of those sound waves. Somebody who has otitis media, who has an infection in their ear, very painful, by the way. We'll talk about that later. But that can be like a cause of conductive hearing loss versus sensory neural hearing loss. So the sensory neural hearing loss, that's going to be something more like related to the nerves themselves, like damage to the cochlea or the vestibular cochlear nerve itself. And the way that you can tell, and it describes this a little bit more down on page 1885, but a conductive problem, like if you put this right on top of, like the tuning fork on top of their head, if you have a conductive problem, you won't hear the sound in the good ear. You will hear it in the ear that has the problem. But in the sensorineural disorder, like the cochlear or the vestibular cochlear one, then if you're doing this Weber test, you won't hear it in the bad ear. You're going to hear it in the ear that doesn't have the problem. So that's how you can kind of determine when you're doing that test, is it conductive or is it sensorineural? So those are the two things that when you're like figuring out, okay, somebody's got a hearing loss, what do I have going on here? So when you're dealing, we talked about last time somebody who is blind, when you are dealing with somebody who is hard of hearing, first of all, in this case, they are going to be able to see you fine, but let's say they're not looking at you. They don't use regular stimuli. They can't, like if you're looking away, you're a regular hearing person, you can hear somebody walking down the hallway. Well, if you're hard of hearing, you don't get that sensory input. So it's possible if a patient is in their room and they're hard of hearing, they're not going to hear or see you coming in. So when you're dealing with somebody like that, you kind of acknowledge them, move your hands, sort of move in front of them, touch their foot, let them know that you're there, and then you want to reduce the extraneous noise. Like I said earlier, extra noise is very hard to hear, so you might need to turn off the TV, you might need to ask other people to stop talking that are in the room, you might need to move to a room that does not have as much distractions or other noise going on so that your patient can hear you. It's helpful to sit right in front of the person so they can read your lips. Some deaf people become very good at reading lips, but they can usually only pick up about 50% of what you're saying, and then they can fill in the blanks, which is how sign language works. They just use like the big words, the nouns, and then their brain will fill in the blanks. So again, you don't want to shout at the person, you just want to talk clearly and succinctly at them. Okay, let me tell you about the only other things really, other than the hearing loss. Otitis media is basically an ear infection that hurts really bad, and it's typically a bacteria. So it used to be that any little kid, little kids get this all the time because their eustachian tubes are much shorter and they're much straighter from the external auditory canal to the tympanic membrane. As we age, it lengthens and kind of goes like this a little bit, so it's not as easy for bacteria to get in there. Children get ear infections, otitis media, a lot. And when you look in their ear, that eardrum will be very red and inflamed and it hurts. So little babies, they'll cry a lot. They'll oftentimes tug at their ears. It used to be that we would put every little kid on antibiotics when they would develop otitis media, but current thinking now is that it's so common and little kids get over it so quickly that just symptom management is fine. Just some Tylenol, Motrin to sort of help the pain, and typically it'll go away. Children that get repeated otitis media over and over, sometimes they have to have eustachian tubes put in, and what that does, it's a little tube right through the tympanic membrane that allows the fluid to flow in and out so that they don't have excessive pressure, because children that have repeated ear infections, they can develop scarring on their tympanic membrane. It can lead to some hearing trouble down the road. That's a little bit more rare. But otitis media that develops in adults is extremely painful, so we almost always treat that with antibiotics, either orally or with drops, sometimes both, and obviously pain management, because it's really painful in adults, although it's less common in adults. So the otitis media is probably the biggest, the most common situation you're going to see with ears, especially if you're dealing with pediatrics. I told you about hearing loss. I wanted to tell you about, I told you about cerumen impaction. Oh, foreign bodies in the ear. This is funny because it's not funny, but it's a little bit funny because little kids love to shove things in holes all the time. So it's not uncommon for little kids to shove something in their ear and then they have hearing loss, or they'll develop an infection and their mom doesn't even know they've shoved something, and they go to the ER, and they've got a toy or a pea or a pebble or something in their ear. It happens a lot, so then you just have to kind of scrape that out. I wanted to talk about Meniere's disease because, and it here it is. Okay, so it starts on page 1897. The reason I want to bring up Meniere's disease is it's probably the most common of the ear disorders. Meniere's disease is an inner ear abnormality, and it typically develops usually after the age of 40, and it's just this incessant feeling of dizziness and vertigo, and that can lead to nausea, because when you're dizzy you tend to get nauseated. And it can last for just a couple of minutes up to several hours. It's very debilitating. The patient can get very tired, fatigued, irritable. They don't want to drive. They don't want to get up and walk because their balance is all off. It does tend to run in families. So if you have somebody in your family that has Meniere's disease, and you start developing vertigo and stuff, it could be that you also have, you're developing Meniere's. There's not a lot of good options like for a cure, but there are some treatments for it. One is just diet. A lot of people do really well with diet control, and the diet consists of low sodium and low sugar, so they should not have really anything canned, because anything canned has a lot of sodium in it to keep it fresh. So most canned things are off limits. You have to have them, read labels, so they shouldn't have sodium. Pickles are very high in sodium. Chips, anything that's salty, and also anything that is sweet. They should not have that. Just because, remember, this is back to our osmosis and fluid and electrolyte days. It just pulls fluid away from the inner ear, so you don't have that excessive fluid and pressure in there. So you do want to just control their fluid balances, and then medications like the antihistamines, because the antihistamines will help dry up things. So we want to just pull some of the extra fluid off of the auditory system in order to help maintaining that balance. So the anticholinergics, sometimes like the sedatives like a Valium and stuff will just sort of help calm that down. Sometimes diaphoretics to pull extra fluid off of that space. The antiemetics, so if somebody is constantly like, I'm getting all nauseated, the antiemetics, like that, those are the anti-nausea so they don't vomit. Those kind of medications will help. So tinnitus. Tinnitus is the other medical word for ringing in the ears. You know, I told you that aspirin can cause it, Meniere's disease can cause it. When they get that zzz, that's that ringing in the ear, that's called tinnitus. It's very debilitating. It irritates. It sounds like you got a mosquito in your ear all the time. Nobody wants that. So then if you look at chart 64.8 over on 1899, that's like how do you help somebody with vertigo, and vertigo is just that wobbly, I don't feel steady on my feet feeling, common with people who have inner ear disorders. And then just really quickly, I want to point out acoustic neuroma is over on page 1902. An acoustic neuroma is just it's a benign tumor that is starting to grow on the acoustic nerve of the ear. Usually it's one-sided. The patient will complain of hearing loss just in that one ear. It does have to be removed surgically, and usually they don't need anything else. Occasionally, if they don't get it all, it will grow back, but it's not going to kill anybody because it's not malignant. You don't need radiation or chemo afterwards, but it's not super uncommon either to have an acoustic neuroma growing right around that acoustic nerve in the ear. And oftentimes those patients will develop photophobia, vertigo, hearing loss, that kind of stuff. So that's probably one of the most common tumors in the auditory system. I think that's it. And then further on is just sort of the implanted devices for hearing loss and stuff. So that's it. That's all you need to know about eyes and ears. Okay.